Today I'm coming at the end. Everybody before me's, been great, and I feel like I want to thank you all for staying till the end of the day and being interested in what I've got to talk about. I'm also chair of the International Nurses Society on Addictions Policy Committee for about 12 years. So I have been quite involved in the policy process, either through my work at the city, the state, or with my organization. I felt the need to put some more of these slides in here, but I want to go through them really quickly because I don't want to waste time. So this U.S. overdose crisis, there were 52,000 deaths in 2015. Of those, over 33,000 were from prescription and illicit opioids. While the previous speakers have noted that, we don't have the full set of 2016 data yet, the estimate is that it's probably going to be about a 20% further increase in opioid deaths for 2016, which would bring it up to around 62,885 people in this country alone. And the overdose deaths are primarily from opioids, including prescription drugs, heroin, and synthetics like fentanyl. And you'll note that the darkest line are the commonly prescribed opioids. And because of things like the prescription drug monitoring database and an increased awareness about the need to change prescribing practices, it's kind of leveled off since about 2008, but you'll see that heroin and the other synthetic opioids are on a steep trajectory since about 2010. In 2016, the fentanyl-related deaths surpassed heroin or prescription drugs, and that line is almost straight with 20,000 fentanyl and fentanyl analog deaths in 2016. And so the rate of deaths from carfentanil has increased 10,000 times. The rate of opioid deaths from fentanyl has increased 100 times. Heroin's on the rise. Morphine's, not as significant of a problem as the fentanyl and related drugs. Okay, so we know that people get their pain relievers most often from a family or friend. So start by looking at the circles on the left. Of the people who were misusing analgesics, who obtained them directly or indirectly by prescription, 36% were from prescriptions, 54% were from a friend or relative. You could say, well, there's room for us to improve in terms of how we store and manage prescription doses, and we have bring back programs for people to bring back their unused medication. But then I personally have a friend who's having a knee replacement today by a doctor who doesn't believe in opioids, and I think this person might happen to have an opioid or two stored away from the last surgery. So I kind of, and I have had a loss of a husband due to cancer, so I fully understand the need to maintain access to opioids for people who truly need it, but we've really been doing a poor job with our prescribing practices. And if you look at the 54% of the people who obtained pain relievers for their most recent misuse, their friend or relative got their medication from their own prescription 87% of the time. Prescription drug analgesics are a large source of the diversion problem. Opioid prescriptions have tripled to more than 200 million prescriptions, not doses, per year in recent years in the U.S. Back in the 90s and up till about 2010, most current heroin users started opioid use with a prescription opioid. A lot of children who got it from their grandmother's medicine cabinet or their mother's purse. But that line crossed in 1990s where heroin was coming down but prescription drugs were going up. But since 2010, the first opioid to be used is more likely to be heroin. And see that dark blue line is going up while some of the other lines are staying relatively stable, like other hydrocodone's coming down a little bit, oxycodone's coming down quite a bit. Other prescription opioids are relatively stable, but heroin is on a steeper trajectory up. And a lot of this has to do with a decline in the relative price per pure gram of heroin. You know, prescription drugs are not very affordable unless you have insurance. You know, if you have to pay the per pill price or per prescription price, it can be quite a lot. But also, I would kind of think, I suspect, and I think there's some science to say this, that when we started limiting access to prescription opioids through the use of prescription drug monitoring programs that would limit doctor shopping and filling too many prescriptions or too early, when people can't get their opioid and they're addicted and they don't, you know, have treatment or medication-assisted therapy, they're going to get their opioid from somewhere. And the speaker who said that it's kind of like the flu but 100 times worse or something, there's also a fear factor among people that are at risk of going into withdrawal. I liken it to like I'm underwater and I need to take my next breath. I'm panicked, I'm going to die, and I need my next dose of an opioid. Or somebody who's in a burning building and they know they're either going to get burned alive or have to jump out the window. That's the kind of irrational, if you were really in a burning building, that would be a rational fear. But when you're having the drug changes that Dr. Welsh talked about this morning, and the neuroadaptation and the neurotransmitter disruption, that's the kind of thinking that people have. So they're going to go buy it somewhere, and heroin is much easier to get than a prescription drug these days. So thank goodness there's an increase in prescriptions for naloxone, because we've got so much prescription opioid and heroin on the streets that we need to protect people from overdose. But the retail prescriptions have increased from the fourth quarter of 2013 to the second quarter of 2016, 9,520%. I kind of feel the need to say, too, that the retail price of naloxone has increased, too, much like EpiPens and other medications that people need. Let's talk about federal health system priorities. The biggest thing is that there's a treatment gap, and the people who need treatment are not receiving it. Only about 1 in 10 people who need treatment are able to reach treatment. And that means 90% of the people are not getting it, including the guy in the case study. You know, if he had been linked to treatment earlier, he might not be at the point where he's got all the complications that he had. And if we wanted to treat people with substance use disorders the way we treat people with other conditions like diabetes, then primary care or hospitalist or internal medicine or trauma doctors would, not just doctors, nurse prescribers or whoever's dealing with the patient, would make a good referral, ensure that the referral was kept, get a copy of the records from the referral practitioner, incorporate the recommendations from the oncologist, hematologist, radiologist, all the other ologies out there. We would be getting records, incorporating those recommendations into the treatment plan for that individual every door they go in, every provider they see. But we don't treat people with addiction the way we treat them like other disorders. The White House Office of National Drug Control Policy strategy for 2016 focused on preventing drug use in the first place in the communities, seeking early intervention, identifying people early before their disease has progressed significantly, and integrating treatment for substance use disorders into health care to support recovery, because there is a waiting list. And by the way, if you've got an IV drug user or a person with HIV who's on a waiting list for drug addiction treatment, you should be on the phone to the state substance abuse director and if they're receiving any amount of funding from the Substance Abuse Prevention and Treatment Block Grant, they're required to ensure that you find a place for that person to get interim services until they can get their place in treatment. And even if it means moving them to other parts of the state. It's not always done. Providers aren't notifying the state, and the states aren't always doing the best job. But I'm a former state person, and I know that that's a block grant requirement. I'm pretty sure everybody in this room knows about Healthy People 2020. So the overarching goals are to have high quality, longer lives free of preventable disease, disability, injury, and premature death, but also health equity and the elimination of disparities, and social and physical environments that promote good health and healthy behaviors across the lifespan. That's the overarching goals. Goals tell you what direction you want to go in, but objectives and focus areas specified in greater detail. And among the top 10 leading health indicators or focus areas, mental health and mental disorders and substance, they're still calling it substance abuse, are two of the leading health indicators, which is going to be funny when I start talking to you about how the efforts to repeal the Affordable Care Act are trying to take away the 10 essential health benefits, but I'll talk about that in a minute. So the Department of Health and Human Services has 3 priority areas for opioid drug-related overdose and deaths: improving opioid prescribing practices, expanding use and distribution of naloxone for rescues of overdose patients, and expansion of medication-assisted treatment. And these are the agencies within the Department of Health and Human Services: the Administration on Children and Families, the Administration on Aging, the Centers for Disease Control, the Substance Abuse and Mental Health Services Administration, the Food and Drug Administration, and the National Institutes of Health. I didn't read them all out, but the ones in red are the ones that have the most influence on mental health and substance abuse services. The NIH, the National Institute of Health, the researchers in this room will know who that is, but the lay members of the audience might not know that the National Institute of Health is the federal funding arm for most of the research that takes place in healthcare. And there's many different centers. There's the Center for the Institute for Drug Abuse, NIDA, National Institute on Drug Abuse, and the National Institute of Alcohol Abuse and Alcoholism are the 2 that we work with the most. But SAMHSA or CDC, they're more like the service delivery arm. NIH is more the research arm. And so the idea is that science offers us solutions, and we know science is under attack these days, right? And I'm not just a conspiracy person. But among the people who still believe that science offers solutions, the 3 strategies that we're focusing on the most is safe, effective, non-addictive pain management strategies. So while I still think there's a place for opioids, I don't think your child, your adolescent needs to get 60 Oxycontins for a tooth extraction, you know. But somebody on cancer deserves it, and their quality of life depends on it. Overdose reversal and opioid addiction treatment are the 2 other, and they're looking for innovation in treatment methodologies. The CDC published the Safe Opioid Prescribing Guidelines in 2016, and the University of Maryland School of Nursing was one of over 200 schools of nursing that took a pledge in 2016 through the American Association of Colleges of Nursing that we would ensure that we infused the CDC guidelines into all of our courses for prescribers. But I teach an undergraduate course in addictions nursing, and even though my students aren't going to be prescribing until they go back and get additional training, I've already incorporated the Safe Opioid Prescribing for Chronic Pain guidelines from the CDC and the recommendations from the Surgeon General report that also came out last year called Facing Addiction in America, because it's nurses on every unit and every aspect of healthcare that deal with patients with substance use disorders, even if they're not in the addiction treatment specialty. Okay. I want to mention some things about chronic pain and opioid prescribing. About 35% of American adults, or 116 million people in the U.S., suffer from chronic pain. It's one of the leading sources of healthcare cost, estimated at about $635 billion per year. And before the 1980s, prescribers were more cautious and opioids played a more limited role, primarily for surgery to manage perioperative pain, pain management following a severe injury, or pain management and comfort at the end of life, especially for cancer pain. But in 1975, the American Society of Regional Anesthesia and Pain was kind of reborn. And in 1998, the American Board of Psychiatry and Neurology and the American Board of Physical Medicine and Rehabilitation joined the American Board of Anesthesiology in recognizing pain management as a unique subspecialty. And opioids started becoming a more commonly prescribed low-cost management approach to many people with chronic pain. That's kind of where we could see a shift in practices. In 1996, the president of the American Pain Society advocated use of pain as the fifth vital sign. The Veterans Administration initiated measurement and documentation of pain as a fifth vital sign. And the expectation was that a score of 4 or higher would trigger a more comprehensive pain assessment and prompt intervention. And then Joint Commission rolled out similar standards in non-VA hospitals. And then Purdue Pharma introduced OxyContin in 1996. And it was marketed from 96 to 2001 to over 5,000 nurses and doctors and pharmacists at 40 national all-expense paid pain management conferences and speaker training conferences, kind of like the Train the Trainer model. And they targeted MDs who were the highest prescribers of opioids. So they went to the ones that were prescribing a lot to begin with, and offered patient starter coupons for free 7 to 30-day supply of OxyContin. And if you work in addictions treatment, don't you know that thing about the first dose is free? Yeah. So it was promoted aggressively for use in non-cancer pain, which increased the prescriptions 10 times in 2002 to 6.2 million. And what did I say earlier, like 200 million prescriptions per year? From 2002, it was 6.2, which was a huge increase to begin with. And the profits to the pharma were greater than 35 billion. So then there was what some people call the criminal misrepresentation of the risk of addiction by Purdue Pharma. And their trained sales force described risk of developing a substance use disorder as less than 1% for patients with chronic pain. Like if you had alcoholism or you were already a drug-dependent person, then they might increase your risk of developing an addiction. But if you were a chronic pain patient, they estimated the risk as being less than 1%. But we know now that the actual risk is somewhere between 8 and 12% based on systematic reviews and data syntheses. So in 2007, 3 Purdue executives pled guilty to claiming that OxyContin was less addictive and less subject to abuse and diversion than other opioids, and they paid a mere $634 million in fines, and there were marked increases in abuse, diversion, and non-medical use and opioid overdose deaths starting in the early 2000s. And by 2004, it was the most frequently abused opioid in the United States. So recently, October 17th, there was evidence on 60 Minutes and the Washington Post that there was collusion by Congress, lobbyists, and drug distribution industry. So until our congressmen start wearing uniforms like NASCAR drivers so that we know who they belong to, we've got to start looking at our electoral system. Bill Whitaker of CBS News authored this investigative report, and it was based on information provided by Joe Ranazizi, the former head of the DEA's Office of Diversion Control. And people started looking at the role of distributors or the middlemen. And Cardinal Health, McKesson, AmerisourceBergen, and other Fortune 500 companies with significant money and influence control 85 to 90% of the prescription drug market in the retail U.S. market. So they ship drugs manufactured by companies like Purdue Pharma and Johnson & Johnson to drugstores all over the country and the world. The deal is, though, that under the Controlled Substances Act, distributors must report suspicious orders to the DEA. And they were consistently failing to report unusually large or frequent shipments. So in Kermit, West Virginia, a town that only had 392 people, when they ordered 9 million hydrocodone pills over 2 years, nobody blinked. And a mid-sized distributor shipped more than 28 million pills to West Virginia over 5 years, with 11 million pills sent to Mingo County, which only has a population of 25,000 people. In 2008, the DEA assessed fines of $13 million to McKesson and $34 million to Cardinal Health for filling hundreds of suspicious orders for millions of pills without reporting them to the DEA. And their fines totaled $341 million over the last 7 years, which is kind of a drop in the bucket for the opioid economy. So then industry struck back at the DEA, and they hired at least 46 investigators, attorneys, and supervisors from the DEA into high-paying jobs within the drug industry and law firms that represent them. And they pressured the top DEA lawyers to take a softer approach. And the DEA bosses demanded more and more evidence before they were willing to make a determination. And people who were leaders in DEA enforcement were reassigned to other duties. And by 2013, the caseload slowed down dramatically, and the success in intervening with suspicious shipments to small towns virtually stopped. And the industry also appealed to Congress. So in 2013, they began working with members of Congress to create legislation that would strip the DEA of its most potent tool in fighting the opioid distribution. And the Marino bill was promoted as a way to ensure that patients had access to the pain medication they need. And they spent $102 million lobbying Congress, claiming that the DEA was out of control. And we know that Congress isn't very hip on regulations with the EPA and other things that save lives. The impact of this industry influence on legislation was that the Marino bill was written by the ex-director of DEA litigation, now senior vice president with Cardinal Health. And it was introduced by Congressman Tom Marino and Congresswoman Marsha Blackburn. And it was presented to the Senate in March 2016, passed by unanimous consent by the House and Senate with no objections and no recorded votes. No recorded votes. So nobody has to be responsible for what happened here. And the actual impact is that it's prevented the DEA from freezing suspicious shipments of opioids. And no distributor shipments of narcotics have been frozen for almost 2 years. And our teenagers are ordering opioids from other countries through the mail and the internet. So since we're trying to clean up Washington and drain the swamp, somebody decided to nominate Senator Marino as the head of the ONDCP drug czar. And it was announced on September 2nd by the White House. But after the thing on 60 Minutes came out, he withdrew his name from consideration. And another pharma executive is now reported to be under consideration for head of Health and Human Services, since Tom Price had to leave because he was flying everywhere on taxpayer money. Okay. So let's talk about push to get more medication-assisted therapy out there. There's plenty of people who think that methadone and buprenorphine are just replacing one drug with another. But I'm here to say that the decision whether you go on a medication-assisted treatment or not is an individualized decision between your healthcare provider and based on a comprehensive biopsychosocial assessment that most people aren't qualified to make. It includes both behavioral therapy and medications. And medication-assisted therapy for opioid addiction is subject to lots of legislation, regulations, and guidelines. If you want to know where to send people and you don't know how to get treatment for them, SAMHSA has a searchable directory of drug and alcohol programs that you can find on the Center for Substance Abuse Treatment website. You can type in your patient's zip code and what kind of specialized treatment they need. If you're looking for gender-specific services for LGBTQ, if you're looking for gender-specific services for women, domestic violence situations, teenagers, Spanish language, whatever you want. And there's also a buprenorphine locator to find physicians that are authorized to prescribe buprenorphine. And I'm going to spin through this quick because I know I'm going to run out of time. The three main legislations around buprenorphine were the Drug Addiction Treatment Act of 2000, which enabled physicians to prescribe opioids for the treatment of opioid addiction in office-based settings and not just in a federally regulated methadone clinic. And because somebody wrote physicians may prescribe, that meant no other prescribers like nurse practitioners, advanced practice nurses, or physician's assistants could prescribe until Senator Markey introduced the TREAT Act in 2015, and it later got rolled into the Comprehensive Addiction Treatment Act of 2016. None of these bills came with funding. Okay. The Drug Addiction Treatment Act of 2000, by offering buprenorphine in providers' offices and non-methadone clinic settings, it increased access to treatment, except that physicians weren't really prescribing enough. They weren't getting the waiver to prescribe it, and some physicians didn't want to work with those patients, and nurse practitioners couldn't. There's three pillars of the Addiction Recovery Act, CARA 2016. Expanding diversion programs that channel individuals caught in low-level drug law violation from the criminal justice system into evidence-based treatment instead. Supports expansion of medication-assisted therapy and expanded use of naloxone for first responders. A lot of these other things, like expansions to the prescription drug monitoring database and other parts of the act, like pregnant and postpartum women and residential opioid treatment programs, were not funded. So it looks great on paper when you say, look what I passed legislation for. But until the budget cycle comes around and the funding's appropriated, you haven't really done anything. One of the deals was that physicians could only prescribe buprenorphine to 30 patients at the time, but it expanded the access. If you're interested in knowing how to get a waiver to prescribe buprenorphine, here's the website, and the conference planners will have the slides. But it's on the SAMHSA website. You can just type in buprenorphine SAMHSA, and the website will come up, and it'll very easily show you how you can obtain the special DEA number. Physicians have to have 8 hours of training because the people who wrote the bill didn't think advanced practice nurses knew as much as physicians. Nurses have to get 24 hours of training, but that's okay. We don't resist training. Okay. And in 5 years, they're going to reevaluate the effectiveness of nurse practitioner and PA prescribing to see if the results are what we hoped for. And if there's not evidence out there, there's nothing to say that this is going to remain as a thing. When it was first written into the TREAT Act, it said that nurse practitioners and physician assistants would be required to be supervised by waivered physicians. So I said before, there weren't enough physicians with the waiver, and of the physicians that had a waiver, not all of them wanted to prescribe. They didn't want them in their waiting room, even though they're in their waiting room anyway, and because addiction's everywhere in all settings. But yours truly, as president-elect of the International Nurses Society on Addiction, said, whoa, wait, Maryland is a full practice state. For this one drug, for this one diagnosis, nurse practitioners have to practice as if they were in a restricted practice state, which limited how much they could practice and required a lot of supervision and delegation, or even a reduced practice state that required collaborative agreements like Maryland used to be. So now that Maryland and 21 other states, or 43% of the states in the country, are full practice states. Even passing the legislation didn't really expand capacity, which is the whole idea, to get more treatment out to more people. So to the person who thought we weren't addressing race, poverty, social determinants, and other things, I don't want to spin through this quickly, but I am almost out of time. Race, education, and poverty and its relationship with substance use disorders. So most of the people in this room know what some of the social determinants of health are. And if you get a chance, write this down, the Rat Park experiment. If I had 5 extra minutes, I would like to play it for you. But this is based on some research that took place in the 70s. And there's some people that question the legitimacy of this research. But what it did was they put rats in a cage and had them press the bar to get more opioids. They got it through the water that they drank. And then they put other rats, like the special rats, in a rat hotel that provided everything you want, just like an upper middle class neighborhood for rats. They had access to sexual partners, they had all good food, and even though they had a water bottle and a bottle that had water with opioids in it, the rats that had their needs met were not abusing the opioids. Only the rats that were deprived of all other not human companionship, but rat companionship and all the good things that rats like to eat, they medicated their problems with opioids. Don't pay attention to this too much, but just look where the dark shaded areas are. Poverty levels in Baltimore, 40 to 100% of population earning under $25,000. The darkest brown parts are the part of Baltimore with the lowest educational opportunity. The red ones are the location of public housing communities. The darkest red are the areas of the city that has the most violence. These are all social determinants of health. Poor schools, I might add. These are the location where the homicide victims are. And unfortunately, the blacks are disproportionately represented among homicides of all causes and homicide shootings of all genders and homicide shootings male victims. Some people in society want to blame the opioid epidemic on urban minority poor people, but the truth is that blacks use substances at lower rates of any illicit drug, cocaine and crack cocaine, relative to white counterparts. And the racial distribution of the respondents of people who used heroin, the black square boxes are the white people, and the little round white circles are the non-white population. So they don't use heroin at higher rates, but they do get targeted for racially discriminative policing patterns. We know from research on racism that we're cutting down black men before their time, that black men in America have lower life expectancy, increased risk of every health problem known, and that this gap persists even when we control for poverty and lifestyle, and it's possibly related to the toxic cocktail of the constant release of stress hormones related to the social determinants that they're raised in a multi-generational pattern of deprivation and poverty. So regarding African American men, this is my population. I work with men being released from prison. I work at our Daily Bread right across the street from Central Intake, looking at the prison system in our back parking lot. And these men either come from prison or drug treatment programs. Black men are more likely to be incarcerated. That's the top blue line. And it's a vicious, multi-generational, multi-directional cycle of race, education, and poverty, criminal justice involvement, and poor access to care. Michelle Alexander wrote a really landmark book in 2010 called Mass Incarceration in an Age of Blindness. And she says, a primary function of any racial caste system is to define the meaning of race in its time. Slavery defined what it meant to be black, a slave. Jim Crow defined what it meant to be black, a second-class citizen. And today, mass incarceration defines the meaning of blackness in America, and especially black men as criminals, and this is what it means to be black in some black communities. They're disproportionately policed and disenfranchised from voting, and like Congressman Cummings says, they do their time, even though they're incarcerated at higher rates and they get stiffer punishments and longer prison sentences, they do their time, but the life sentence is the felony conviction on their record. 1 in 15 African-American men are incarcerated compared to 1 in 36 Hispanic men and 1 in 106 white men. And 1 in 3 black men can expect to go to prison in their lifetimes. It's a critical link between healthcare and jails. They carry a heavier burden of illness. Sometimes the jail is their only source of healthcare. They come out of prison with no medicines and no Medicaid card and no ID card with which to get the Medicaid card. And I'm running out of time, but anybody who doesn't want to leave, I'll keep talking. And anybody who wants to leave, please feel free to do so. Okay.